Thanks for everyone coming. This is the 10 a.m. session. I have the pleasure of introducing our speakers for today. So Ciara Gurley is a physician assistant who works alongside Dr. Nicole Tartaglia at the Extraordinary Kids Clinic at Children's Hospital, Colorado, providing evidence-based family-centered care for children with X and Y variations. Her role on the team includes follow-up developmental evaluations as well as medical management of common co-occurring conditions like ASD, anxiety, ADHD, depression, gastrointestinal disturbance, sleep difficulties, and challenging behaviors. And I will also introduce Dr. Middleton, although if you were here for the last session, you'll already know her, but she is a licensed psychologist and an associate professor of pediatrics at the University of Colorado School of Medicine. She's a practicing psychologist in developmental pediatrics at Children's Hospital, Colorado, and is one of the psychologists on the Extraordinary Kids team. She provides evidence-based assessment and consultation to families of children of all ages with X and Y variations. Her research and clinical interests include the assessment and treatment of autism and co-occurring mental health conditions, sexual and reproductive health in individuals with neurodevelopmental conditions, and neurodivergent, gender diverse youth. So thank you very much.
Good morning, everybody. Welcome. We have a nice, small, intimate crew in this huge room. So we'll do the best. If questions come up, feel free. I think some information on your all's unique path in this shared journey in caring for our young children and teens and adults with X and Y variations. So I would love, since it is a smaller group, if you guys don't mind raising hands just so I can see children like 0 to 5. Okay. And then like 5 to 10. Okay. And then older than 10. Okay. Thank you. That's helpful. So let's get started here. Generally speaking, today we're going to learn about the symptom presentation of both ADHD and anxiety and how that is unique in this population of individuals, as well as talking through the treatment options and modifications that we work with in treating these individuals. During today's lecture is that we are not endorsing any specific medications, brands, companies of medicines. Generally speaking, it's really challenging and unethical, truly, for us to make specific recommendations for your child without evaluating your child, although we're more than happy to answer general questions and help provide some guidance as far as next steps on that. All of that to say, if you are interested in this medication conversation, it should be a conversation you bring back to their practitioner, whether that be their primary care, a psychiatrist, a developmental pediatrician, whoever you are working with on their team to have these discussions. And given not all of these medications are approved to use in young children, we are oftentimes using them off-label. With that being said, kind of general overview, when we think about the X and Y variations, all of them truly can have some variable degree of differences in brain development and function. And so that puts these individuals at risk of cognitive learning differences, some of which developmental delays, learning disability, intellectual disability, this behavior, emotion, regulation differences, as well as the social differences with things like social immaturity or autism. Comprehensive list, and I know this is not news to all of you, but wanted to give that big picture overview and highlight today, we're really focusing on that ADHD and anxiety piece for these kiddos. So we like to call this our ADHD anxiety flower. And again, kind of not news to all of you that each individual petal on this flower can be an area of challenge for these individuals, both in and of itself, right, with language delays and mood instability, for example. But what I really want to highlight and drive home for this particular image is the interplay between all of these is very complex. None of them really occur in isolation. And when we're looking at this ADHD and anxiety picture for these kiddos, all of these individual pieces can really contribute to exacerbating those symptoms. So for example, sensory differences, if we're out having a hard time in public with loud noises or stimulated environments, that can contribute to heightened anxiety for these kids and teens. Medical considerations, it's not uncommon for these individuals to have like gastrointestinal differences and challenges. And if we have medical appointments and procedures and medications, that can oftentimes really heighten anxiety. clinician to take a step back and say, how do all of these components fit together? And then how does that guide our treatment decisions for them? So we'll start with the ADHD piece. Globally speaking, attention deficit hyperactivity disorder. We get a lot of questions on like, what about ADD, which we don't really use that terminology anymore, as opposed to right now, we look at this ADHD umbrella, and underneath that umbrella, there's different presentations that these children can come in with. So there is a hyperactive or impulsive subtype, which oftentimes looks like more of these external outward behaviors. There is an inattentive subtype, which implied in the name has difficulties with attention and focus and sustaining task. And then it's also very common for these children to come in and have a combination of both of these types of presentations. In thinking about prevalence, the literature is highly variable as far as what these numbers actually look like, but general trend is they are much more prevalent than in the general pediatric population. And presentation, generally speaking, these are not exclusive. And so although it is more common for those with an extra X chromosome to present with this inattentive subtype of ADHD, it is not exclusive. And by all means, they can also have hyperactivity and impulsivity. But generally speaking, this is more of the presenting problem that we see versus those with an extra Y chromosome. Oftentimes they're coming to us with more of that hyperactive, impulsive subtype with then some inattention symptoms underlying that as well.
Okay, so I think last talk I did and this one, my job is to go from statistics to real world. What do we see? What do families tell us? And what we hear in terms of hyperactivity and impulsivity for young kids, parents say it's like he's running on a motor. He's constantly running out of the classroom at school. She's getting in trouble a lot for hitting and pushing at school. He climbs on everything and is very unsafe. He walks around the house while he eats his dinner and will not sit in his chair. She runs into the street and does not stop when I say no. So you can see these things are getting in the way, both for safety reasons, home, and in different contexts for the family. She has a really hard time waiting her turn when playing games, also causing problems socially. Sitting for circle time at school is really hard, again, at school. So for inattention, what we hear is, and these are obviously just some of the things we tried to summarize a broad range. But for inattention, he gets distracted by the smallest things. He's constantly bouncing from activity to activity. She can only focus on a task for 10 seconds at a time. It's like he's in la la land. He never listens. I have to remind her 10 times to put her shoes on. She forgets her backpack at school 4 days out of the week. So what we are looking at here when we think about a diagnosis, so some of these might be behaviors and things that you're seeing in your child, but they may not have a full diagnosis of ADHD. What really kind of the frequency of symptoms increase, intensity happening, and it's causing a lot of problems. And impairment, and it's happening across multiple contexts. So it's affecting social and school, academics, learning, peer relationships. It's affecting the family. So we're seeing kind of a pattern of causing problems or challenges day to day.
Just one other quick medical plug when we think about diagnoses. It's tricky, and it's our job as a clinician when these children come in. It's oftentimes clear to us, right, when they're in the office, if there is like impulsive or hyperactive behaviors and they're up and down off the table and grabbing things off the wall. And although we can talk ad nauseum about ADHD, it's also important for us to take a step back and think about, are there other contributing factors in this child's presentation that maybe underline and that we really need to work to treat to see if that makes a difference on daytime behaviors. And so, for example, here, if there's hearing or vision concerns, that can play a huge factor. Sleep difficulties or sleep apnea is a huge one we see, where if sleep challenges or if there's untreated sleep apnea at play, hyperactivity and inattention symptoms during the day are rampant and can significantly improve as these sleep challenges are addressed. And then not uncommon to see thyroid problems. We'll oftentimes check labs for that, as well as, although seizure disorders are not common, if there is some underlying medical component with seizures that can impact, again, attention, learning, gaining of skills. So we want to make sure we're also broadening our diagnostic approach to make sure there's nothing else underlying that we need to be thinking to treat before we jump into more ADHD specific treatment or coinciding with what we're doing for the ADHD specific treatment.
Okay, so treatment considerations. So I'm not going to talk about all of these things. We're really going to focus on the at-home strategies and medications. But I wanted to just share that all of these kind of supports occur in the context of families and home, because families and parents and caregivers, you're with your kids more than anyone else. You know them better than anyone else. And so all of these types of supports, behavior therapy, speech therapy, OT, really occurs in the context of the family environment. But I want to touch on a few at-home strategies. And these are not specific therapies, but you may have heard of some of them in therapies you've done or in your own research. And some of these are more specific to young kids, although they can all be tailored to teens and young adults as well. The first one is special time. So for really young kids who are a little bit more active, maybe inattentive, having that, what special time is having one-on-one time with parents every day. And it may seem like I'm saying that and you're like, I do that. I'm with my kid every day. This is a little bit more specific where it can literally be 5 minutes. And I'm not saying 5 minutes and I mean 10 minutes. I'm really meaning 5 minutes a day where it's you and your child together playing what they want to play with or doing what they want to do. So you're not directing anything. You're not giving them any demands. You're not asking them any questions. You are just all focused and positive attention on what they want to do. And that special time, I think about it as money in the bank for when you have to then give a demand or a question or a consequence for something later on. So you're building up that positive relationship. So then when you have to draw on that for some consequences, that's there. You can do this with teens too. Although I don't know if teens want to hang out with their parents, but it's okay. You can find other ways. Maybe they want to go get ice cream. Maybe they want to watch a TV show, trashy TV together, whatever it is that they are kind of into, you're there with them kind of following along what they want to do. And you'll notice that all of these at-home strategies are pretty positive. So I'm not going to talk about consequence-based strategies today. I will give a resource at the end that has some consequence-based strategies because there is a role for consequences. But I really wanted to focus on some of the more positive strategies that tend to work for hyperactivity and inattention. Rewards are I'm sure you've all heard about rewards and use rewards. I am a proponent of easy reward systems. I do not want you to have this elaborate checklist of things that you have to remember. How many points is he earning for this? And then I have to track it. And then I have to add up the points. No. I want you to do a super simple reward system where if there is a point system, it's a jar of marshmallows or it's a jar of cotton balls or marbles that you're adding to. And when it gets to a certain level, there's the reward. Or it's a reward in the moment. It doesn't have to cost anything. It could be praise. It could be high fives. It could be, hey, I love how you just got your shoes on. I'm going to give you some iPad time in the car on the way to school. So it can really be a super easy, straightforward reward system. This could look like movement breaks where I will often say, you know what, let's get up and do 10 jumping jacks. Doesn't have to be a reason. You don't have to explain it. You just kind of get up and do that movement together. It could be kind of broken up throughout the morning or the afternoon. Those movement breaks can really help kind of get the wiggles out. Setting up the environment for success. So if you know that morning routine is rough, it is for me in my house with my little one, and we are chronically late to things. I try to set everything up in the morning, the night before, that I know we're going to be doing. So lunch stuff is out, clothes are set out, and we just kind of work through those pieces. And if you have a little one that is really active or, has trouble kind of staying on task, having things set out ahead of time is really going to be helpful. And then also setting clear expectations and predictability. So this picture here is a time timer. How many of you have time timers at home? I love these. I have one too. So it lets your child know, and you can use this with older kids too, or teens. There's apps that are really helpful with these things. So this is one way to set up predictability for how long something is going to last and when it's going to be over, because that often will ramp up activity level and inattention. So having those clear expectations can be helpful. School modifications. You heard a lot about this yesterday in the executive functioning talk that I know was very well attended. So a few things that I'll highlight here is having some ongoing support and extra time to process and extra time to plan and organize, and using lots of visuals. Feel free to take a picture of this because I'm not going to go into too much detail here because we've talked a lot this weekend about school accommodations.
Okay, we are going to shift into the medication conversation. We'll start with ADHD and then we'll talk through anxiety more later. A few things before I jump into it. So if have come to see us at all in Colorado and met with myself or Dr. T, you've probably heard this before. If you've come to any of our medication lectures, you've maybe heard this before. But I want to ensure that you all understand repetition in these scenarios is very important. And you may have been at a point when you came to see us or talked with your practitioner of saying like, yeah, it's good information and we're not quite there and we're not quite ready. The next time you come around, we talk about it again and you say, sure, this is starting to resonate a little bit. And then maybe the third or fourth time we have the conversation, you say, we're ready and we're in a spot to start this. All of that to say, we talk about it and normalize it because we do this day in and day out as far as prescribing medications in very young children, as well as through adolescence and adulthood. But recognizing as we talk through this and present it, I also recognize as a practitioner that these are very heavy conversations for families. And I know these decisions are not taken lightly. And there's a lot of weight to them when we talk about starting a medication for our child. And that's very important to us. And we hear you when you bring up those concerns in our visits. And that's what we're here to help talk through and address those concerns that you all have. So with that being said, generally speaking, we think Dr. T has these 5 reasons that we all reference back to. But the conversation that I start with families is as we're going through symptoms, whether that be, again, ADHD, anxiety, depression, irritability, whatever the symptom is, we take a step back and say, is that particular symptom causing some sort of level of distress impairment difficulty in really any one of these 5 areas. So health and safety is a huge one. If there's elopement concerns, if your child's running into the street or through the parking lots, self-injurious behavior concerns, concerns for other safety with impulsivity, academics and learning, particularly with this ADHD piece, if it's starting to get in the way of their learning and accessibility to this content and progressing their academic skills. If there's difficulties in the home environment. So we hear oftentimes it just takes us 45 minutes to put on their shoes and get out of the house in the morning, and we're all stressed, and there's this just chaos in the morning, and it's every single day. And we cannot get past these things no matter what behavioral strategies we start to implement. Social development and friendships, not only from a social emotional standpoint, which we can see in these individuals, but if there's an ADHD component and we're kind of bouncing around from activity to activity, or we can't sustain a game with a peer for a period of time, that can really impact their ability to have these lasting friendships. And then lastly, if there's a self-esteem piece. So it is not uncommon, unfortunately, for kids with an ADHD profile to get in trouble kind of a lot, or to get yelled at by the teacher a lot. Or need all of these reminders and kind of stand out amongst their peers, particularly in the school environment. And these kids can internalize these behaviors and think I'm bad, or why am I getting in trouble so much compared to my peers? If any one of these areas are impacted, that's typically the time where we say, I think it's time to have this conversation and at least initiate some conversation around it. And generally speaking, kind of the ideal time to have this conversation is when we're not in crisis mode. We're just curious to learn about the medicines and what they do and why we use them, versus it's much harder to have these conversations if we've kind of waited it out and watched, and now we're in crisis mode and there's a lot of difficulty. And some of these medications, as I'll get into, take some time to work. And so if we're already in that crisis mode, that causes an additional level of distress. And so I encourage you, wherever you're at in the journey, with or without medications, to take a more proactive decision. We want to weigh the risk and benefit. And I put this little table in here, and that I encourage you, if you're in a place to have this conversation with a practitioner, either do this at home beforehand or bring it with you to the appointment and say, like, can we go through this? And what are the benefits of starting the meds? And what are the risks of starting them? As well as, what if we don't start them? What is the benefit of not starting it? Like, we don't have to worry about side effects and appointments and lab draws and costs, or the risk if we don't start them and the behavior is continuing. This is a nice one to take a picture of. And so again, if you're ever in a place, I don't need to go through all of these questions individually, but if you're in a place of having this conversation with your practitioner, I encourage you to come in with questions, because as we have the conversation and overload you with information on the specific medications, you're going to have a million thoughts running through your head, and the ability to kind of think through thoughtful questions in that moment is really challenging. I think the highlights of it are importance of like administration of the medication. So what time do we give it? How do we give it? Is it with food? Can we crush it? Is it a liquid? But then most importantly, if we have difficulties with it, how do we get a hold of you? And that could be, is it best to send a my chart? If it's on a weekend or a night, is there on call? How do we get some sort of guidance if we're in a place where we have questions? So generally speaking, again, kind of the initiating medications part in children generally, regardless of their age, we take a conservative approach and we go very, very low on the dosing and we titrate it slowly. And so I generally counsel families of, it may be that this first initial dose we start with doesn't actually result in a whole lot of improvement in symptoms, but we want to make sure they tolerate it okay. And if they do, then we gradually work together to increase and titrate this dose until we start to see some improvement. You'll oftentimes hear Dr. T talk about this is a team. Your child is a team captain. And as we think both about initiating medications, but then also checking in on the efficacy of how the medicines are working, we want to involve everybody at play here. So the child is obviously the most important and how they're feeling. And I have been impressed so many times with the child's ability to really express to us, whether it be side effects or hopefully from an improvement standpoint, how it's helping their body and making them feel. But for those who are not able to necessarily express those thoughts or questions to us, we obviously parent involvement, everybody else involved in the home, but school personnel is really helpful input, especially with these ADHD medications I'll go through, as well as like therapists, mental health providers, so forth, that the child is working with. Generally speaking, there's a whole host of medicines that we can start with. And so to better hone in on which one may be the best fit to try first, we want to think of these target symptoms. And so generally we say X, Y, and Z are problems right now. Which one is at the forefront that we want to try to improve first, recognizing there may be others down the line that we can address. And how is it getting in the way? And then that helps us as a practitioner really hone in on this particular type of ADHD medication may be a good one to start with. And then timing, I always emphasize with families, there's never a great time to start or stop meds. However, we do our best to isolate this change at one time. So for example, it's probably not a great idea to start an ADHD med the first day of school. Or the first week of school. If the kid is a little dysregulated, we have a hard time with the shift in environment, it's really hard for us to tell, is it because they're not tolerating the medicine, or is it because we have this other environmental change that's contributing to some of this difficulty? So as best we can, we try to isolate really as stable as we can environment outside of the medication change, and one change at a time with medicine. So if they have multiple medications on board, or even supplements, things like melatonin and so forth, we want to change one thing at a time. And that really helps us isolate the benefits of this particular medication. Generally speaking, stimulants are first line when we talk about ADHD treatment, and they work. They 80-ish% of kids that take these medications experience some sort of benefit with it. With that to say, we'll go through side effects, and there's absolutely possibility of side effects as well. But generally speaking, they're very, very effective medications, and we use them very commonly. The way I have found to best describe these to families, because I get questions all the time, especially for young children, of my child is already hyperactive and impulsive. Why am I giving them a stimulant medication to further stimulate them and ramp them up? And it works on the dopamine in the frontal lobe part of the brain. And so the way I describe it to families is that we are helping to stimulate this area of their brain that helps us to pump the brakes, and it helps with executive function, and it helps with impulsivity and reasoning. And it's helping us to better access that part of our brain. Generally speaking, we use these to treat both the hyperactive impulsive behaviors as well as attention difficulties. And there's two main classes within these stimulant umbrella. And there's the methylphenidate products, which a few listed here, if you've heard of any of those: Concerta, Ritalin, Focalin, and the amphetamine products is the other category as far as meds like Adderall and Vyvanse, et cetera. Benefits, as I had said, they generally work pretty well. With that being said, they don't work for everybody. And oftentimes it's a little bit of an art for us as providers to try a few different ones to see which one provides the most benefit for the child. It's lovely if it's the first one we try, and majority of the time it's not, and that's okay. And we reassure families there's a lot of options and ways that we can help to navigate this. But I like these meds because they work the day you give them. You give it in the morning generally, and they work throughout the course of the day, depending on how long of a formulation it is. And then they're out of their system by that night. And so for some families who are a little bit more hesitant to say, I don't really want my kid on a med every single day, these are nice options because you can give it Monday through Friday for school and take a break on the weekends. Or for other families who say, during the summer, he doesn't really need it because we're doing camp and other activities. And that's okay. So you can take a break from these medications really at any point you want, and then you just restart them on the days that you need them. Along the lines of that second bullet point, if for whatever reason they forget a dose or they miss a dose, you don't get the benefit of it that day, but it's not dangerous to miss a dose, and there's no withdrawal or side effects if you don't take a dose on a particular day. There are both long and short acting formulations. And so dependent on the child and kind of how quickly they metabolize the medication, sometimes we're using them once a day, sometimes we're using them twice a day, or like a little booster in the afternoon if the child needs something to help cover the end of the school day, or like homework, after school activities. And there's a lot of different ways, regardless if the child can swallow pills or not, for us to prescribe these medications, as far as capsules that can be opened up, or tablets, and there's liquid options. Is a decrease in appetite, which I counsel families occasionally gets in the way enough to say we need to try something different, but majority of the time, maybe a decrease in appetite when the med is at its highest peak in the system, but they eat a good breakfast, a good dinner, some snacks, and we make up for it throughout the course of the day. Sleep disruption, typically we only see if we're giving a dose a little bit later in the afternoon. There's a possibility of it bleeding into the evening hours, but generally speaking, if they just take it in the morning, that's not as much of a problem. And then with this irritability and emotionally flat, it's always going to be a potential side effect. But when I talk with families about this, the goal with these medications is never to take away your child's sweet little personality and goofiness, right? And so if we're seeing that with the medicine, it's not the right role of their body and their thoughts, but it should not take away their sweet little personality. And if it does, we need to make change. That's not the goal of these medications. And then rarely, but occasionally, if a child already has a tremor or tics, it can sometimes exacerbate those. And if there's underlying cardiac concerns, we run it by our cardiologist before we start these medications. The other main class we use in treating ADHD symptoms are these non-stimulant medications. So guanfacine and clonidine are the two main ones that we use. They work a little bit differently in that they target the alpha receptors in the brain. Treating the same type of symptoms again, although they typically work a little bit better for more of that hyperactivity, impulsivity standpoint. And the reason we like these meds is they help with those core ADHD symptoms, but oftentimes when kids also have difficulties with sleep or behavior regulation, they can have a little bit more of a positive impact on those behaviors, as well as if they do have tics, it can actually help to suppress the tics. The risk with these, though, because they can be helpful for sleep, is that if children take them during the day, occasionally it can make them a little tired or fatigued. And they do work to mitigate blood pressure effects as well. And so we are cautious and keeping an eye on blood pressure if the child is complaining of dizziness or lightheadedness, making sure it hasn't dropped their blood pressure too low. And then our children with baseline constipation, again, not common, but occasionally it can worsen that constipation. So another thing we counsel families on to just keep an eye on.
Okay, we are going to shift gears now to talking about anxiety. So first, we all want to be on the same page. What is anxiety? It's a human condition. Everybody in this room, myself included, has most likely felt anxiety at some point in their life. That doesn't mean you have an anxiety disorder, but it means that we just know what it feels like. Anxiety is good in some aspects, right? It helps us get up in the morning and do what we need to do and prepare for giving a talk to an audience of people. It helps us if there's a bear in the woods and we need to get out of there. It lets us know that fight or flight. So it is useful and we need to have some anxiety. But when anxiety gets to be too much, too persistent, too intense, and it starts getting in the way and causing problems, that's when we need to do something about it. And that's the kind of anxiety that we're going to be talking about today. So the components of anxiety is kind of unique in that there are these three pieces of it. So there's the physiological piece, and that's the one that I think of as being really uncomfortable. That's why people show up to the ER saying, I'm having a heart attack, I'm having heart palpitations. And sometimes it's anxiety because it's so uncomfortable. It's sweating, it's stomach aches, headaches, dizziness, heart palpitations. Then there's the cognitive piece, which is what your brain tells you, your anxious brain saying, and it's usually some kind of distortion. Like on the flight here, I had a lot of this through the turbulence from Colorado to Georgia. The plane's going down is what my brain was telling me. Get me out of here. I can't handle this. Those are anxious thoughts, or it could be catastrophizing. I'm never going to be okay. This is going to last forever. The behavioral piece, what we typically see are three things: avoidance, getting out of the situation, leaving the situation, whatever that is. Birthday party, not even going to the birthday party, that's avoidance. Not getting up in front of the class to give a presentation, that's avoidance. We see reassurance seeking, asking questions. It's cloudy outside. Is it going to rain today? Is there thunder? Am I going to be okay? Are we going to be late? Is there going to be a substitute teacher? Is there going to be a fire drill? all of those kind of reassurance questions. And then the third thing is anticipation. So before even getting into that situation, before going to the birthday party, what if I don't know someone? Feeling anxious before I get on a plane? Is there going to be turbulence? That's all anticipation. And sometimes we just see one of these things. Most often we see all three of these things. Often helpful to know what are kids most commonly worried about. And there are 4 buckets of things that kids, including kids with X and Y variations, are worried about. So one is social. That's a really big one. So it's, what do other people think about me? Am I going to be bullied? Am I going to be rejected? I also don't want to walk into a room and have everybody look at me, that unwanted social attention. The second area is chronic worry. And these are kind of like the generalized worries or generalized anxieties. So big topics, war, climate change, school, grades, all of those things, lots of different worries. Separation is another big one for young kids. And it's not just separating from caregivers or parents, but it's worrying about something bad happening to the parent or the caregiver or to the child. Something bad's going to happen to me if I'm not with my mom. And then specific fears or phobias. And the most common ones that we see, although there's a wide range, fear of animals or dogs, bugs, the dark, and crowds. There's also some specific sensory worries that we hear a lot, loud noises. There could be fear of changes in routine, fear of not being able to do the thing that you really want to do. So there's a lot of different kind of specific fears. What we hear from parents in terms of anxiety concerns, he has to have a lot of preparation before an activity. He has to know what to expect. And this is because anxiety likes to control our brains. And the more we know ahead of time, our anxiety thinks it will be relieved. And that is often a false idea. So the more control we have, it's a false sense of security. We don't actually have that much control, turns out. She refuses to go to the playground at school. She's sensitive to transitions. He hides his face or will cling. He has major tantrums anytime we're outside the home. She won't speak in certain situations. Every time we go out, he asks over and over when we're going home. So you can see how this can get in the way and cause problems. I just want to say one piece about parental protection, because anxious kids sometimes, not always, oftentimes have anxious parents, although it's not causal. It's not, I don't want you to leave here thinking I'm an anxious parent and I made my kid anxious. Absolutely not. But we know that anxiety runs in families, my family included. And so parental protection is really important to talk about because kids with X and Y variations often require more support and ongoing support. And so as a parent, you are an advocate for your child. You are in that advocacy role. And so some of that is protective, protecting your child. There are 2 kinds of protection. So there's adaptive protection and excessive protection. And notice that I'm not using the word overprotection. I don't like that word because as a parent, you need to protect your kid. That is your job. But there are some better ways to protect and some ways that you could think about shifting that protection. So adaptive protection is when you know your child's skill set and you decide, okay, now I'm going to push because I know that my child has the skills to do this. They're a little bit afraid of it, but I'm going to push them because I know that they have the skills and you know when to protect. I don't think they have the skills to go to this birthday party all by themselves and not know anybody there. I'm not going to push on that one. I'm going to go with them. Excessive protection, this is the protection we want to be careful about. This would be protecting at all costs. You're afraid of going to a birthday party, you don't ever have to go. So I'll always help you. I'll always be there, regardless of your child's skills. And so we want to be, it's a balance. It's not always perfect. We're human. We're going to go into situations and maybe sometimes excessively protect. And that is okay. You can just rethink about it and try something next time. But I just wanted to call this out because it does have a big role in anxiety. And when we talk about treatment of anxiety, it really comes into play. So a big example that I usually give is when I was doing some work with a family. The child was afraid of trying new foods. And there were a lot of fears about texture and tastes and all of these things. But he had the skill set to make a choice. And I trusted that he would choose something that he could successfully try. We went down to the cafeteria. He picked like some avocado, something, and his mom was with us. And when he picked it out, she went, "Oh, are you sure? I don't know." And so we had to have a talk about that. That is kind of an indication of excessive protection where we got to trust him. He's choosing this, and we're going to kind of see and let him flounder a little bit and push a little bit, but she wasn't quite there. She had been burned in the past when he had, big reactions to trying these foods. And so it comes from a place of real lived experience, but it was something that we had to talk about because it can undermine trying new things and trying to kind of be brave when your child is trying to be brave and do hard things. Okay, so treatment considerations, again, occurs in the family and home environment. So you could do therapy all day, every day, and not make any changes at home, and anxiety can be really persistent. We're going to focus on mental health therapy and medications when we talk today. So CBT, you've heard a lot about cognitive behavior therapy this weekend, I'm sure. For anxiety, it is the treatment of choice. And I want to empower you as parents and caregivers when you look for CBT for anxiety, it really needs to have two main components: psychoeducation and exposure. A lot of providers most therapists do psychoeducation and somatic management, which is managing your body, and then cognitive restructuring, managing your mind. Most providers do this. There is variability in providers who offer exposure therapy for anxiety, but that is the key ingredient. We can do psychoed all day. We can know what we're anxious about. We can know how to calm our bodies, calm our minds. But if we don't do the things that we're afraid of, anxiety treatment is less effective. So I always encourage parents when they're looking to get anxiety treatment to ask directly, will you do exposure with my child? And exposure just means doing the thing you're afraid of and facing fears a little bit at a time. So the main components, you've heard a lot of these strategies this weekend. I like to break them down into two different pieces. One is calm your body. We always start with that. It's okay if you hate deep breathing. I'm not going to force you to do deep breathing. Okay. So a lot of families or kids are going to be like, "Oh, I'm going to go to therapy and they're going to make me do deep breathing." No, there's lots of other ways to calm your body. There's mindfulness, there's petting a dog or your pet or your cat or your snake, whatever you have. There's yoga, there's music, there's lots of other strategies. And I like to break them down into daily strategies and in the moment strategies. So daily strategies are just like the things you do every day to kind of keep baseline. So for myself, I really like to bike ride. I don't bike ride every day, but I try to bike ride a couple times a week and get outside, especially in the summer. And that's like, if I don't do it one week, I am a cranky person and don't want to be around me. So those daily strategies, if it's like drinking tea before you go to bed, reading a book, things that you do to kind of keep your sanity, those are daily strategies. And you want to help your kids develop some of those for themselves too. And then in the moment strategies, those are going to look a little bit different because I can't take my bike to work usually and just go ride it when I'm frustrated with my boss or something like that. I need to have other strategies in the moment that are going to be helpful. And you want to do this collaboratively with your child. So what happens a lot is we often will say, here, try this, do some deep breathing, try this in the moment. And your child is like, what? We've never talked about this before. I don't like it. I hate deep breathing. Don't tell me to calm down. And now you're locking horns. And so this is a collaborative approach. Talk about, what's going to work for you. Here's some options. Pick the ones you like and we'll try it. If it doesn't work, we'll try something else. And then calm your mind. So I am a fan of mantras. And for a lot of kids, they cannot come up with their own calm mind strategies. So we just have some mantras that we do. And you can model this as a parent. You can, when you see that your child is anxious, they don't have to say it. You can just say, I'm brave. It'll be okay. I know I'm safe. I can do this. That's just my worry talking. And you can model that yourself. You don't have to have your child do it too. And then be brave. And this is facing fears a little bit at a time. And I do think that you can do this at home without the help of a therapist, but it is often helpful to have a therapist. And we want to start low and go slow, just like with medications. So we're not throwing kids into the deep end with facing fears. It's not fear factor up in here. It is low, slow bravery with lots of rewards and positive reinforcement. And then there's lots of modifications that we want to think about for kids with X and Y variations. And there's some overlap here with, a lot of different diagnoses, modifications that I would use with kids with IDD, with autism, with speech language delays. These are great strategies for a lot of different learning styles. Plain language, really simple, straightforward, not making things too complicated, using lots of visual supports, multi-sensory, experiential. The more we can do with our hands, the more we can go out there and experience what it's like to be in these situations, and repetition over and over and over again. And then I'll give some books at the end for some parent and child specific anxiety work. Okay.
Okay, a few pieces on medication considerations from an anxiety standpoint. Now we're going to focus. So I'm not going to go through again, kind of initiating that conversation as we've already talked about that, but did want to plug in a quick reminder back to these 5 reasons, right? Are these symptoms impacting safety concerns? Are they impacting our home life? Are they impacting the individual's academic performance or school participation? Are there friendship, relationship concerns impacted by the anxiety? And is their self-esteem impacted? Generally speaking, I will say too, this is not a comprehensive list of anxiety medications. These are generally the ones we think to first start with when it comes to treating children. However, by no means is this comprehensive, but generally speaking, these are the first ones we're starting to think about. So the SSRI class, which works on the serotonin receptors in our brain, it helps to increase these brain serotonin levels, which helps not only treat anxiety, but for some kids with a mood component or depression component, it can be helpful for those as well too. It's a common question I get if you Google these medicines. This is a depression medicine. Why are we using this to treat my kids' anxiety? And they're used to treat both, and they're really effective for both. So generally speaking, when we use these meds, we're thinking the anxiety, shyness, withdrawal, panic attacks, irritability, these symptoms that they're presenting with, we're hoping to improve. And a list of medications on the right-hand side here that are common within that class that we're using for children. Mood, anxiety piece gets to calm down. But in kids, this can look a little bit different. And so the transition, sometimes it helps with transition from activity to activity or transition to appointments. This somatic presentation we get with kids having stomach aches or headaches or picking their skin, biting their nails, we're hoping to decrease some of those behaviors, freeing them of their worries or this perseveration that might come about. and just an overall ability to tolerate change and unpredictability. We occasionally in the X and Y variations will see more of this like selective mutism presentation of individuals with anxiety, particularly for trisomy X. And so the goal would be to, in different settings, that we're able to increase some of their speech language use. Generally, they're very well tolerated. Same type of idea, and that we go quite slow and conservative with our dosing. And they take a little bit longer to work. So these ones take more like 4 to 6 weeks to really see full benefit. And so I encourage families as we're getting them started, give it a little bit of time and patience. And it leads back to my previous comment of not a great time in crisis mode when we're needing the benefit of these medications to bring up this conversation for the first time. That is not on you all as parents, that's on us as practitioners of recognizing here are these early signs where we need to start these conversations. And so we're not coming in a year later in crisis, needing one of these medicines, and now we have to wait a month for it to work. Very well tolerated, though. Occasionally, if there is, again, increase in agitation or other symptoms like insomnia, sometimes we're able to combat it with changing the time that we give the medication. And other times it may be that we need to just try something a little bit different. And then generally, the GI symptoms are transient and improve with a little bit of time. Again, lots and lots of other medicines we can use for anxiety, but in children, these are ones we're commonly thinking about as well. And these can either be in addition to the previous ones I had just talked about, or in isolation. We use both. So propranolol is a medication that works on the beta receptors and can be taken in children and adults, both in short and long-acting formulations. So sometimes it's a daily med, sometimes we just use it situationally for flights or the dentist or appointments. And it helps to prevent that like panic-like fight or flight response. Generally speaking, because of the receptors it does work on, there can be some dizziness or low heart rate as side effects. Mirtazapine we really love because from a side effect standpoint, it can cause some weight gain and tiredness. But for a lot of the kids we see, those are problems. They have low appetite and they don't sleep. And so not only can it help to benefit mood and anxiety, but it can sometimes help from a sleep standpoint, as well as for those with a poor appetite, it can help to increase that. Side effects that if it does cause too much of an impact on weight gain or appetite, we need to keep an eye on lab work as far as their cholesterol and liver function tests, and then it can cause a little bit of constipation. And then hydroxyzine we also use quite often, again, can be more of an as needed medication, although it also can be given daily and can be very helpful for sleep, especially if there's an anxiety component associated with the sleep difficulties.
Okay, we've been talking a lot this morning in this room about challenges and difficulties, but we want to end on strengths because kids and teens with X and Y variations have a ton of strengths, and we want to highlight those, celebrate those, trying to treat attention or anxiety or mood. And so some of the kids that I've worked with, they're super creative, they're super social and into drawing and expressing themselves in different ways. They're really amazing visual spatial learners. And so using some of these strengths is really important as we're working on some of these other areas. Here are some resources for ADHD. I love this Russell Barkley book, Taking Charge of ADHD. This is for parents. And 1, 2, 3 Magic. This is for younger kids. I have used it with my own child. And it does talk about consequence-based strategies as well as some of those positive strategies. And then this one is for younger kids. My Mouth is a Volcano. Any of the Julia Cook books, if you look up Julia Cook, she's got some great books about attention, anxiety, kids might have, and this is for kids to read with their parents or on their own. And then Anxiety, Freeing Your Child from Anxiety, Tamar Chansky. That's a great one for parents. And then Ruby Finds a Worry, and When My Worries Get Too Big are for kids. Thank you all so much, and we can take a few questions.